introduce our lecturer for the day. She is BS Biology graduate, magna cum laude from Pamantasan ng Lungsod ng Maynila, and the rank 6 and the Doctor of Medicine in Pamantasan ng Lungsod ng Maynila, College of Medicine in 2004. And she finished her Master's in Public Health in UP Manila College of Public Health in 2018, a clinical fellow training for infectious diseases in UPPGH, and currently in 2006 and 2000 until 2008, she had her residency training for internal medicine in Hospital ng Maynila Medical Center. Ayun. And with a lot of her achievements and credentials, let me just introduce our lecturer for antiretroviral therapy, dosing, and side effects, Dr. Evelyn Rojas. Ooh. Good morning, Doc.
Hello, good morning. So thank you very much again to SHIP, especially to my batchmate, Kate, for inviting me to deliver this lecture. Hello. Hello to all the participants. May nagpapabate yung taga Paranaque. Cisco daw. Dr. Karen Galvan, hello. Saan? Sige. Shout out, no? Share. Okay, so we'll start with the lecture. We'll start.
Wait lang, wala po. Iba.
Okay po. So I'm tasked to discuss ART dosing and side effects. So this is part of your Module 1, which is basic management of HIV and AIDS. So for this session, the following are my objectives: to acknowledge the importance of discovery of antiretroviral drugs, of course, to understand the different types of ARVs, its mechanism of action, but mainly I'll focus on the dosing and side effects since that's the assigned topic for me today. And I'll just update the latest recommendation on the use of antiretroviral drugs for treating and preventing HIV infection, coming from the latest 2016 WHO guidelines on use of ARVs. So to start with, so I don't know if you've seen this, but just a short introduction of the timeline of ARV approval. So we all know that in 1987, the first NRTI, or the first antiretroviral drug, was discovered with silovidine. And through times, 1995, we have the protease inhibitor, or your PI. In 1996, your non-nucleoside reverse transcriptase inhibitor. And then from then on, early 2000 was the more newer antiretroviral drugs, fusion inhibitor, and the latest is the entry inhibitors like your integrase inhibitors. So the last ARV discovered was, in this timeline, is the Maraviroc, discovered last 2007. So currently, there are 51 DOH treatment facilities offering antiretroviral drugs in the country. As of August 2017, total of 22,413 persons living with HIV are currently enrolled on ART, which is about 33% of the estimated total number of PL-HIV by the end of 2017. However, by 2022, the goal is to provide antiretroviral treatment to 90% of PL-HIVs. Later on, I'll be discussing the 1990 recommendation by WHO. So this is the natural history of HIV disease. Why am I showing this to you? So without the antiretroviral drug, kung walang medication, itong natural course of the disease. However, with the advent of the antiretroviral drug, it was said that HIV, from a death sentence, it was now turned into a chronic disease. Agree po ba? Agree. So through global efforts like research and financial aid, effective medication was discovered, and a turning point came with the discovery of your antiretroviral drugs. So statistics or evidence support that highly active antiretroviral treatment, or your HAART, improves outcomes of HIV patients or HIV/AIDS patients. So with the discovery of antiretroviral drugs such as protease inhibitors in this figure, there was also a concomitant decline in the number of mortality or deaths of the patients. So what is the goal of treatment? Why do we give antiretroviral drugs? The main goal is to maximize viral suppression. So it is the main goal so that after that, we can restore and preserve the immunologic function of the patient, reduce the HIV-related morbidity and mortality, and eventually improve the quality of life. So take note, still not a cure for the antiretroviral drug, but we want to maximize the viral suppression so that patients can have the mga from death sentence to a chronic disease. So they can have improved quality of life. So let's talk about the individual antiretroviral drugs or your ARVs. How do they work? How do ARVs work? So take note that human immunodeficiency virus or viruses in general are considered as obligate intracellular organisms. So all viruses are obligate intracellular organisms, meaning that they mainly depend on the synthetic process of the host cell. Diba? Unlike the extracellular organism or extracellular bacteria, so si virus mainly dependent on the host cell. So this is the reproductive cycle or the life cycle of HIV. Hindi naman kailangan i-memorize yan. So why am I showing this to you? Because our antiretroviral drugs mainly depends or attacks or the mechanism of action is dependent on the stages of HIV replication. For example, our one group of antiretroviral drugs, so namely your fusion and entry inhibitors, so they main act on the first stage of HIV replication, which is when the HIV enters the CD4 cells. So other antiretroviral drugs like your reverse transcriptase inhibitors also act on this stage of HIV replication. So later on, I'll be discussing in detail the mechanism of action of different drugs. So I just want to show here that it is important that we understand the natural life cycle or the HIV replication because the antiretroviral drugs acts on this specific stage of HIV replication. So to be effective, antiviral agents or antiretrovirals must block the viral entry or even the exit, or it should be active inside the host cell. Okay, so non-selective inhibitors of viral replication so that it will interfere the host cell function and eventually leading to toxicity. So let's discuss the individual ARVs. So starting with the first group of antiretrovirals, so your NRTIs or your nucleoside reverse transcriptase inhibitors. I don't know if they have separate lecture on mechanism of action. Nevertheless, so padaanan lang natin. So NRTIs, from the name itself, inhibit the viral enzyme reverse transcriptase. So what is the action of your reverse transcriptase? So this is the enzyme responsible for transcribing viral RNA into double-stranded DNA. So this enzyme, this helps the production of new virions. So when you have nucleoside reverse transcriptase inhibitors, so what they do is that they mimic the other nucleosides and are incorporated into the DNA strand. I don't know if you see dito sa figure, if you can see sa figure, so the action of your reverse transcriptase inhibitor. So it attacks or it mimics the other nucleosides and thus preventing the addition of the natural nucleosides into the DNA strand. So it is important to understand this because the other class of your antiretroviral, which is the non-nucleoside reverse transcriptase inhibitor, although it has the same, it also attacks the reverse transcriptase enzyme, it has somehow different mechanisms. So see, NRTIs, so it prevents the addition of the natural nucleosides into the DNA strands. Yun ang mechanism of action. So I'm sure you know what are the common nucleoside reverse transcriptase. So most commonly used, we have tenofovir, lamivudine, abacavir, sidovudine, emtricitabine. So I highlighted here the ones available in our country. Okay, so the other NRTIs, you have your didanosine, slavudine, and salcitabine. So I'll be mentioning the common NRTIs in the country. You have first your zidovudine, so abbreviation AZT. Hirap yung mga letters, no? Zidovudine, also known as azidothymidine, kaya AZT. Okay, so one of the first NRTIs, when you use it, side effects includes headaches, fever, nausea. So that simple side effects, but it can also have more severe complications or toxicities like rash, and one of the most common complication is anemia and neutropenia. Okay, so this condition, however, these side effects were found to be reversible upon reduction or discontinuation of the said drug. But take note that I want to highlight here that for zidovudine, it can cause lactic acidosis, which of all these side effects considered as the medical emergency, and somehow it might warrant stopping the medication and admitting the patient, checking the ABG and lactate level, because it is considered nga as a medical emergency. Another NRTI is your lamivudine, so 3TC. So ano peculiar with lamivudine? It's also an anti-hepatitis B drug. So compared to your zidovudine, said to be more tolerated with lesser allergic potential. However, it still has the potential for lactic acidosis. But as compared to the other NRTIs, they are the ones that should be disconsidered when you're suspecting of lactic acidosis as side effect of your NRTI. So other side effects of your lamivudine, you have nausea, diarrhea, headache, and it can have more severe complications like liver disease and worsening hepatitis B among those already infected. Okay, so it has high-level resistance associated with the M184V mutation, and has long-term and is associated with a resistant hepatitis virus YMBD mutant. So next you have your tenofovir, so TDF or your tenofovir disoproxyl fumarate. Okay, so it has higher barrier to resistance and very good activity. Actually, if you have an HIV/HBV co-infection, it is the drug of choice together with your lamivudine. Side effects associated with your tenofovir includes your nausea, occasional dizziness, diarrhea, headache, and just like the first two NRTIs, also associated with lactic acidosis, liver toxicity. Very important with tenofovir, is that it has the potential to cause the Fanconi-like syndrome, diba? Pang-exam. So it is associated with Fanconi-like syndrome side effects. So you have to be careful when you're giving this drug to those with avoid in renal failure or with renal problems. Okay, so tenofovir has low allergy potential. It is considered as pregnancy category B, but it can pass through breast milk and can have a serious side effect on a child who is breastfed with, who is receiving the breast milk. So next NRTI, we have M-tricytabine, so FTC. It is usually in fixed dose combination with your tenofovir or in triple combination of M-tricytabine, tenofovir, and efavirenz. So side effects as compared to the first three is unusual, but you can also have diarrhea, headache, nausea, and rash. More severe side effects may experience like hepatotoxicity and lactic acidosis. So in general, the NRTIs, the main, if you can see, the main adverse effect is on the mitochondrial toxicity. So it has increased risk for lactic acidosis. So we have to monitor this side effect. It can also cause increased transaminases and sometimes can cause lipid metabolism disorders. So let's now go to the second group of your antiretrovirals, your non-nucleoside reverse transcriptase inhibitors, or your NNRTIs. Okay, so common NNRTIs, we have efavirenz, nevirapine, rilpivirine, and delaverine. So as I've said, its mechanism of action, it also inhibits the reverse transcriptase enzyme, but have a different mechanism of action compared to your NRTI. So the action of your NNRTI is that it binds directly to the reverse transcriptase enzyme. So nucleoside reverse transcriptase inhibitors, saan siya? It prevents the addition of your nucleoside. But for your non-nucleoside, okay, from the name itself, non-nucleoside, it binds directly to the enzyme, so reverse transcriptase enzyme. And eventually, the effect is the same with that of NRTIs, but somehow different mechanism. So let's discuss the individual NNRTI. So first, you have your nevirapine. This is the older NNRTI. Nung nag-fellowship kami, hindi naman gaano katagalan. Puro nevirapine pa, no? Meron na, bago pa lang sa efavirenz. But this is an older NNRTI. So side effects include rash, headache, nausea, feeling tired, and hepatotoxicity. And as we all know, very notorious with your nevirapine is the severe skin rash side effect that can sometimes lead to severe adverse effect of SJS or Stevens-Johnson syndrome. So we have to remember that nevirapine should not be used concomitantly with your anti-TB drugs, particularly what anti-TB? Your rifampicin, because your rifampicin can decrease the level of your nevirapine. So it is noteworthy also to mention that nevirapine has low barrier for resistance due to your K103N mutation, but as compared to your efavirenz, can be more safe for use during pregnancy. Efavirenz, another NNRTI, is generally well tolerated, but very common side effect is that it can cause vivid dreams. So we should watch out for this side effect or adverse effect to our patients. Avoid in patients with suicidal ideation. As compared to your nevirapine, it has low potential to cause rash and SJS and can be used together with anti-TB. So when you're having a TB HIV patient, so it is recommended to use efavirenz rather than nevirapine as the NNRTI drug of choice. So efavirenz is said to be teratogenic and as much as possible should not be used among pregnant women. So NNRTI, in summary, the adverse effects, you have your skin rash, gastrointestinal side effects, and they say that HIV-2 is intrinsically resistant to your most NNRTIs. So the third class of your antiretroviral drugs, you have your PIs, protease inhibitors, hindi ako nagmumula. Protease inhibitors, lahat ng may mga navir. You have your lopinavir, ritonavir, darunavir, okay? All of these protease inhibitors. So from the name itself, madali lang naman ang mechanism of action. So protease inhibitor, but what is the function of your protease? So protease is an enzyme responsible for cleaving polyproteins into structural proteins and reverse transcriptase enzyme. So this is needed to form a fully mature HIV, human immunodeficiency virus, that is able to replicate and produce more virus. So when you have protease inhibitors, this prevents this enzyme from doing its job in the later steps of the viral life cycle. Okay? So, hindi mako-convert si immature HIV into a mature HIV when you have a protease inhibitor. So, let's discuss the individual PIs. You have your lopinavir, ritonavir. So, this is a combination protease inhibitor. Ritonavir is used for its boosting effect for your lopinavir. Common side effects for your PIs include your diarrhea and very usually associated with them are the metabolic or your lipid abnormalities. Okay, so it can have more serious complications such as pancreatitis. It has higher barrier to mutation as compared to your NNRTIs, but the problem is that it's more expensive, although it's available naman in our country. And it has several drug interactions like with rifampicin, your PPIs, and statins. So your PIs is safe for pregnant, but special precaution should be given for those with structural heart disease or ischemic heart disease or cardiomyopathies. Later on, I have a table summarizing the toxicity profile of these antiretroviral drugs. So adverse effects include redistribution and accumulation of body fat, so very associated with your PIs, diba? You have central obesity, dorsal cervical fat enlargement, facial and peripheral wasting, okay, Cushingoid appearance. So you have to monitor also your lipid profile because it has a tendency to increase the triglycerides and LDL. So we have to have a baseline lipid profile for our HIV patients when we are giving protease inhibitors and glucose intolerance. and insulin resistance. So ritonavir is rarely used for its own antiviral activity. Usually, it is combined with your lopinavir for its boosting effect, but remains widely used as a booster for other protease inhibitors. Okay, so I've mentioned three of the major classes of your antiretrovirals, but there are other classes of ARVs also, including your fusion inhibitors. So enfuvirtide, but it's not available in our country. But just to mention its mechanism of action, so from the name itself, fusion, so it disrupts the HIV-1 molecular machinery and the final stage of fusion with the target cell, thus preventing uninfected cells from becoming infected. So it prevents in the fusion step of the HIV replication. Okay, so it has an adverse effect of local injection site reactions, sometimes hypersensitivity reactions, and eosinophilia. Okay, so yan, so fusion. In this figure, you can see that your fusion inhibitors prevent this stage of attachment or fusion of the virus to the cell. Another class of your ARV, you have your integrase inhibitor. So it blocks the action of another enzyme, your integrase, a viral enzyme that inserts the viral genome, the HIV genome, into the DNA of the host cell. So integrase inhibitor is said to be useful in salvage therapy for patients whose virus has mutated and acquired resistance to the other drugs. So you have your integrase inhibitors like your raltegravir and elvitegravir. So later on, I'll be mentioning the latest WHO update with regards to your integrase inhibitor. Ano ba si integrase inhibitor? Lastly, we have your CCR5 inhibitors. Okay, so anong class of antiretroviral to? So we have one antiretroviral under this class, your Maraviroc, but again, not available in the Philippines. Okay, binds to the CCR5 receptor on the membrane of human cells like your CD4 cells. Okay, so this binding prevents the interaction of your HIV GP120 and the human CCR5, which is then necessary for entry into the cell. So with CCR5 inhibitors, it prevents it's a co-receptor, CCR5 is a co-receptor, so it prevents the entry of the virus into the cell. So it does not prevent HIV entry into the CXCR4 attachment or co-receptor. So it only acts on the CCR5. Okay, so CCR5 inhibitors. Okay, so knowing all of these antiretrovirals, yung main topic ko is what are the toxicities associated with these antiretroviral drugs. So WHO tabulated the different ARV drugs and associated toxicities with these drugs. And what is the suggested management? Okay, for example, your AZT, ano nga po si AZT? Your sidovidine, ang main toxicity associated with it is severe anemia, sometimes neutropenia. Okay? And being an NRTI, it is also associated with lactic acidosis. Okay? So, if really severe ang anemia, what is the suggested management? Substitute with other NRTIs like your tenofovir, okay, which has a lesser toxicity as compared to your sidovidine. So DTG, ano si DTG, dolutegravir, is associated with hepatotoxicity and hypersensitivity reactions. Okay, so if DTG is used in the first line and there are hypersensitivity reactions, you have to substitute it with another class of antiretroviral drug. So another antiretroviral, you have your efavirenz. So what class of ARV to? NNRTI. So yan. It is a major type of toxicity is that it's associated with central nervous system toxicity such as dizziness, insomnia, abnormal dreams. So you have vivid dreams, or even more severe anxiety, depression, or mental confusion. Okay, so for CNS symptoms, WHO stated this recommendation that you can use a lower dose of efavirenz, okay, at 400 milligrams. Nakita ko dun sa case ninyo kanina may question if we can use if you have this side effect associated with efavirenz, and if you can use lower dose of efavirenz. So WHO actually stated that you can use a lower, it is a possible alternative to decrease the side effect, lower dose of efavirenz at 400 milligrams. So ano bang usual dose ni efavirenz? Diba 600? So sabi ni WHO, pwede ang 400 milligrams, but the problem is that we don't have the 400 milligrams formulation of efavirenz. So maybe later on we'll have the discussion on that. Pero pwede, it is an alternative. Or if really severe, then we have to substitute with another class of antiretroviral drugs, so that like PIs or integrase inhibitor. So other adverse effect of your efavirenz, you have convulsions, hepatotoxicity, and yes, efavirenz can also be associated with skin and hypersensitivity reactions, although more severe nevirapine, more notorious nevirapine in causing skin and hypersensitivity reactions. So other class of antiretrovirals, you have your lopinavir, ritonavir. So this is a protease inhibitor. Medyo maraming adverse effect associated si lopinavir, ritonavir. So you have this electrocardiographic abnormalities, diba? So people, more at least are those with a pre-existing conduction system disease or those with concomitant use of other drugs that may prolong the PR or QRS interval. So you have to use with caution in people with pre-existing cardiac problems. Okay, so it is also hepatotoxic. Okay, so you have to monitor this. It can have severe effect of pancreatitis, dyslipidemia, and sometimes diarrhea. So it's all tabulated here. Nevirapine. Okay, so as I've said a while ago, it has the major type of toxicity of skin rash and hypersensitivity reaction that can even lead to more severe SJS, or Stevens-Johnson syndrome. So if hepatotoxicity is, if you have hepatotoxicity, then you can consider substitution with other class of with other antiretroviral, okay, for severe hepatotoxicity and hypersensitivity. So TDF is tenofovir. Okay, these are the major types of toxicity na nabanggit ko na kanina associated with Fanconi syndrome. So we have to be careful when we are giving tenofovir for those with renal problems. Okay, so when we see this major type of toxicity, take note, these are major types of toxicity. So when we have these major types of toxicity, we can do substitution with other antiretrovirals. Okay, okay, so that's for the toxicities. What about the different drug interactions and the suggested management? Okay, I want to mention pala that all of this I got from the 2016 WHO guidelines on the use of ARV. Okay, so let's continue with the ARV drug interactions and suggested management. No, sabihin mo lang next slide. Next slide. Sorry. Sorry, may clicker. So in this table, you can see the different antiretroviral drugs and the key interactions with other drugs and what is the suggested management. So we have sidoviudine, so it has key interaction with your ribavirin, another antiviral drug, and interferon. So the suggested management is to substitute it with sidoviudine, substitute it with tenofovir. So your PIs do have key interaction with your rifampicin, okay? So you're one of the anti-TB drugs also. So the recommended management is substitute. It's either you substitute rifampicin with rifabutin, which we don't have here. However, you can adjust the dose of the PIs or substitute with So listed are the other key interactions with your PI. So your statins. So your PIs also can have an interaction with your hormonal contraceptives. So it's important that you take note of this because when you have HIV pregnant patient, female patients taking hormonal contraceptives. So you should know that your PIs can have an interaction with your hormonal contraceptives. And the recommendation is to use an alternative or an additional contraceptive methods aside from that of the hormones. So PIs can also have interaction with your another antiretroviral drug, your tenofovir. So you have to monitor renal function. So next slide, please. Next slide. Next. Next na. Ayan, sorry. So your DTG, ano si DTG, dolutegravir, has interaction with your other drugs used for CNS, like your carbamazepine, phenobarbital, and phenytoin. So you have to use other alternative anticonvulsant agents. Next slide, please. Iglalagay. So your efavirenz, yan. So just like your PIs, it can interact with your hormonal contraceptives also. And the suggested recommendation is use an alternative or other contraceptive methods to prevent HIV transmission and unintended pregnancy. Back, please. As efavirenz can lower the efficacy of some long-acting hormonal contraceptives. Okay, so lastly, we have nevirapine. So nabanggit ko na kanina that it can interact with your rifampicin. So when you have an HIV-TB co-infection, so you cannot use nevirapine. So you have to substitute it with efavirenz. And all the other key interactions with other drugs is shown in this table. So next slide, please. So knowing these toxicities and then interactions, so it's really important. The message here is that before starting antiretroviral, the patient should really be prepared that he or she will take that antiretroviral drug for life na, di ba? So some of the preparations for a patient for HAART is that you have to treat active or other acute illness before starting the antiretroviral therapy. You have to give appropriate OI or your opportunistic infection prophylaxis. You have to educate the patient for adherence. So later on, I'll be defining what is adherence as compared to your compliance only. And you have to educate them of the adverse events. Diba? Knowing all of these toxicities or adverse effects, it will never be easy for a patient to take those antiretroviral drugs. So we have to do a lot of proper education. Okay, para hindi sila mati-turn off sa pag-inom ng antiretroviral drugs. And we have to remember always that just like in any management of your HIV patient, so starting with antiretroviral treatment requires a multidisciplinary approach. You have to have the help of nurses, social workers, PharmD, and of course the doctors. Next slide, please. So, sige, next slide. So in selecting a regimen, so we have to consider its potency, tolerability, okay, as I've said, the drug-to-drug interactions, because some drugs, antiretroviral drugs, can have several interactions with other drugs. The comorbidities, again, adherence. The CD4 cell count is very important in your choice of antiretroviral drug, and even the gender, okay, whether male or female. Next slide, please. Sige, next slide. So WHO guidelines on the use of antiretroviral drugs stated that, sige, next slide, recommends that all people living with HIV should receive antiretroviral drug. Okay, so for the first time, recommends that all people living with HIV be provided with antiretroviral therapy. And the recommendation now is, next slide please, is treat all. Okay, so WHO, next slide. WHO removes all limitations on the eligibility for ART among people living with HIV. And they recommend a once per day combination pill as a form of treatment. So fix those combinations. Next slide. as I've said in my first part of my lecture, so they recommend now, next slide, yeah, yung 1990 targets, 1990 targets. So it includes 90% of the people living with HIV should know their HIV status, and of this, 90% who know their HIV status should receive antiretroviral drug, and 90% of the people receiving ART should have a suppressed viral loads. Okay, so that's the 90 targets by the WHO. Next slide, please. So the WHO recommends lifelong ART to all children, adolescents, and adults, even pregnant and breastfeeding women living with HIV, regardless of CD4 cell count. Okay, they also mentioned here in this latest guideline the recommendation to offer pre-exposure prophylaxis. And I just want to highlight here that they've mentioned here as an alternative first-line treatment, the recommendation of including integrase inhibitor. Ano ba yung mga integrase inhibitor? Si dolutegravir, okay?
Routing.
As an option in resource-limited settings. And also, they mentioned here the reduced dosage of a key recommended first-line drug, particularly your efavirenz, to improve tolerability and reduce cost. Na-mention yan ni WHO. So, next slide, please. Okay, so ito lang yon. So, these are some of the recommendations also coming from WHO. I want to highlight here the timing of ART for adults and children with TB. So in the new recommendation, they still mention that ART should be started in all TB patients living with HIV, regardless of CD4 count. But specifically, they mentioned here that TB treatment should be first initiated. We all know that TB should be first initiated by ART as possible within the first 8 weeks of treatment. Okay? However, when you have a more profound immunosuppression HIV patient, so ART can be given within the first 2 weeks of initiating TB treatment. Okay? So particularly for those patients with CD4 count less than 50. Okay, so first 2 weeks, kapag naka-anti-TB drug na kayo for the first 2 weeks, then you can start with your antiretroviral drug. Next slide, please. Another issue regarding timing of ART initiation, also from the WHO guidelines. So immediate ART initiation is not recommended in those patients with HIV-infected patients with cryptococcal meningitis. So cryptococcal meningitis is one of the opportunistic infections that can be seen among HIV/AIDS patients. So they stated that ART, in some instances, ART should not be immediately started because we don't want to have the occurrence of IRIS, or your immune reconstitution inflammatory syndrome. So one of that instance is that when the patient has cryptococcal meningitis. So to avoid IRIS, we have to somehow delay the initiation of ART. So in HIV-infected adults, adolescents, and children with cryptomeningitis, so ART should be deferred until there is evidence of clinical response to antifungal therapy. So usually they recommend after 4 weeks of induction and consolidation treatment with your antifungal, or after 4 to 6 weeks of treatment with high dose of oral fluconazole. So for some instances, like your cryptomeningitis, HIV patients with cryptomeningitis, they don't want to start with ARVs right away. So you have to wait for around 4 to 6 weeks before you can start your ARV, so that you will not have IRIS, occurrence of IRIS. Next slide, please. So these are the common recommended dosages of your antiretroviral drugs, individual antiretroviral drugs. So you can see there your lamivudine, zidovudine, tenofovir, okay, your efavirenz. The recommendation is 400 to 600 milligrams once a day. Next slide, please. So how about in our country? So those are the WHO guidelines. How about recommendations in the Philippines? Next slide. So we still follow the WHO guidelines, but there are some specific conditions or guidelines appropriate to our country. So ARTs should still be initiated in all persons with confirmed HIV, regardless of clinical and immunologic status. However, the timing of ART initiation in the presence of opportunistic infections shall be delayed to prevent adverse effects of IRIS. So I've mentioned a while ago that if you're treating with TB HIV co-infection, you have to wait for 2 weeks before starting antiretroviral drugs. From the time that you start with your TB medications, you have to wait 2 weeks before giving antiretroviral drugs. When you have cryptomeningitis patients, as I've said, around 5 to 6 weeks. So 5 to 6 weeks after starting antifungal and CMV. So cytomegalovirus, particularly CMV retinitis, another opportunistic infection among HIV/AIDS patients. So here you have to wait for around 2 to 3 weeks of treatment with CMV retinitis before you can start your antiretroviral drug. So it's very important that we take note of this so as not to compromise our patients. Again, early identification of TB among persons living with HIV shall be done through careful assessment of signs and symptoms and diagnosis. So we recommend now the use of Gene Expert for faster diagnosis of TB among persons living with HIV. Next slide, please. So adherence shall be assessed and reinforced every follow-up visit to prevent drug resistance and treatment failure. So we don't want whether it's clinical, immunologic, or virologic failure. So we have to assess this. It's part of our responsibility. Patients already stable on their current ART regimen shall be maintained on said regimen and monitored accordingly also. And all HIV-exposed infants shall be given ARV prophylaxis at birth or when HIV exposure is recognized postpartum. Next slide, please. So this is the recommended regimen for adults and children greater than 10 years old in our country. Okay, so the first line regimen, we still follow the 2 NRTI backbone plus 1 NNRTI. So the preferred first line drug in our country is TDF. So you have tenofovir plus 3-TC or your lamivudine. An alternative is abacavir plus lamivudine. Okay, so abacavir is preferred over tenofovir for patients with renal problems, particularly those with creatinine clearance of less than 60 ml per minute. For the first line NNRTI, the recommendation is efavirenz in our country. RPV, lipivirine is an alternative NNRTI if you cannot use efavirenz. However, there are certain conditions wherein you can only use RPV or lipivirine. So it can only be initiated for asymptomatic patients 12 years old and above with CD4 count greater than 350, so non-pregnant and not on rifampicin-containing regimen. It is also contraindicated your ripivirine unstable.
Yeah.
Next slide. Okay, so for children, I'm not an pediatric infectious disease, but I will mention this. I will mention this recommended regimen for children. First line is for your NRTI is abacavir plus tenofovir. An alternative first line is zidovudine or
Naghang ata si na Doc Eva.
ayan.
Yeah.
Okay, so
Wait. Wala tayong audio.
okay, so konti na lang. So monitoring our patients while on antiretroviral therapy. So we have to monitor the ARV toxicity So the following are the minimum laboratory tests in monitoring for ART toxicity. So you can request for this test. So for tenofovir containing regimens, since its main adverse effect toxicity is with regards to its renal toxicity. So next slide. You can monitor your creatinine within 6 months of initiation, then every 12 months or as needed. For efavirenz containing regimen, you have to monitor your lipid profile within 6 months, then every 12 months or as at 2, 4, 8, 12, and 24 weeks after starting residovidine. And for PI containing regimens, you have to monitor the lipid profile, TG, cholesterol, and LDL, and even your fasting blood sugar within 6 months, then every 12 months as needed. So next slide, please. Sige, next na. May animation pa kasi. Okay? So monitoring response. So the first one, monitoring for toxicity. How about response to treatment? Okay, so we have to monitor positive response to treatment seen in clinically stable patient with no recurrence of opportunistic infections and with improvement of weight and well-being, stable immune status based on clinical assessment, viral suppression, and improved quality of life. So clinical response, frequency of clinical monitoring shall depend on the patient's response to ART, but should be followed up at 2, 4, 8, and 12 weeks after starting ART, and then 6 months once patient has been assessed to be stable. So next slide, please. So we have to watch out for, we have to watch out for clinical failure. So what is clinical failure? It is defined among adults and adolescents as the presence of new or event indicating severe immunodeficiency after 6 months of effective treatment. However, we have to distinguish clinical failure DAO should be differentiated from IRIS, wherein there is exacerbation of previously coexisting clinical infection. So next slide. Aside from clinical failure, okay, or clinical response, we have to for virologic response. We don't want virologic failure. Next slide. So, back pa po. Sorry. So viral load assay shall be done 6 months after initiating ART also to detect early virologic failure. And virologic failure is defined as viral load above 1,000 copies at any time beyond 6 months. Ito lang yung monitor mo. Next slide, please. Next slide. Okay, so these are summary, the recommended tests for monitoring and approaches to screening for co-infections and non-communicable diseases. So again, before initiation of ART, you have to have this baseline test. And while receiving ART, I've mentioned this a while ago, the laboratory test that we have to request. Next slide. Oh, yeah. I've mentioned a while ago the importance of adherence when we're talking to our HIV patients. Adherence is the act or quality of sticking to something and the act of adhering acceptance of an active role in one's healthcare as opposed to your compliance, which is just the act of conforming or yielding to a particular condition. So of course, we want adherence rather than just compliance. Next slide, please. So how much adherence is required? So the goal of antiretroviral treatment is to do maximal and durable viral suppression, and successful HIV therapy requires more than 95% adherence to achieve this. So failure rates increases sharply as adherence decreases. Okay, so we don't decrease in HAART improves outcomes. The goals of treatment are mainly to maximize viral suppression, eventually leading to improved quality of life. Okay, so I've enumerated the different types of antiretroviral drugs and the individual drugs under that class with their mechanism of action, its side effects, and its drug interaction. So we have to monitor the side effects and drug interactions, and the specific management depends on the specific side effects. And one important note is that the timing of ART initiation in the presence of some opportunistic infection shall be delayed to prevent adverse effects of iris or your immune reconstitution inflammatory system. Ayan,
Thank
thank
you
you.
so much, Doc Eva.
Saan na? Next pa, next pa. Hindi pa
Meron
tapos
pa?
yan. Oo, next
Ang
mo.
kulit.
Ay, OMG!
Ayan. Batchmate ko po kasi yan si Kate. Next mo pa.
Oh
Ayan.
my God. Nakita mo ba yung
11
kaibahan ng
versus-
itsura?
Ha?
Look at the...
Dito ako, Dr. Roman. May next slide pa yan.
Meron pa? 2011.
2011.